Thank you everyone for coming. My name is Taylor Bucyk. I'm one of the R2s in our program in anesthesia here, for those of you that have not met me. And my grand rounds is titled Wild Wild West, Are You an Anesthesia Cowboy? And hopefully you got my survey I sent out. We'll go over that later. And I know you're all eagerly anticipating the results from that. So some objectives that I wanted to cover. How do we define risk-taking in the context of anesthesia? I really wanted to look into what factors contribute to someone making a risky decision, and how can we minimize our risky decisions and make safer choices in anesthesia. And the reason I chose this was I know lots of residents will attest to getting conflicting messages sometimes from different staff, and so not necessarily in processes of how we do things, but how we think, and then you definitely see different thinking processes between staff when you're working with them, so different decision making, and I wanted to kind of answer that question for myself. So a couple topics I'll go over throughout the presentation, and then in each topic I'll try and cover sort of a historical example of when something went really wrong and try and relate it back to anesthesia in the end. So what is risk? This is risk when you're driving in Banff and you see people approaching wildlife like this. This game of Risk is a terrible board game that people play. I don't know why. This seems like a better version of that game. But, anytime you put Nicolas Cage in a film, you're taking a huge risk because you're not sure what he's going to do. This is a photo of my dashboard. I take a risk every day when I drive because that emergency light's been on for 4,000 kilometers and I haven't done anything about it yet. But the biggest risk I've taken in my life is this haircut I had in 2007, which I thought looked good at the time. But okay, so I liked this definition of risk: any consciously or non-consciously controlled behavior with the perceived uncertainty about its outcome and about its possible benefits or costs for the physical, economic, or psychosocial well-being of oneself or others. But there's other terminologies when we're talking about risk. So everything we do in anesthesia has risk associated with it. So that's risk management. We're managing the inherent risk in what we do. And that is the assumption that there is an advantageous benefit to what we're doing. So we accept that that risk is okay, and so that's why we do a general anesthetic for someone. But risky decision making is adding extra, risk or problematic safety issues that don't necessarily need to be there. And there's not always a benefit or a payoff to taking that risk. And acceptable risk is kind of the same thing, but it's always based off of the current values or literature, what we know about anesthesia. So things that weren't acceptable before are probably acceptable now, and it changes over time. So just to start things off, are we inherently risk takers as anesthesiologists? I found some silly paper that just looked at all different types of specialties and had them do some coin flipping task and looked at the results. And I'll have you know that surgeons and anesthesiologists take greater risks than all other physicians. So it's just at baseline we are apparently risk takers. So my topic was kind of based off of this paper I found that came out this year in the BJA. And I sent all the same questions out to everyone. So you actually already have a bit of some knowledge about what the paper was about. And it was in the UK at Oxford. They did an online questionnaire and they collected the data over 2 weeks. It was sent to 212 anesthesiologists, including residents. And again, yeah, Oxford and the NHS Trust Foundation. They had 11 scenarios. I sent 10 because I didn't want to pay SurveyMonkey to send an 11th question. And all the scenarios were actually based off of critical incidents that had happened in anesthesia. And they screened all the scenarios by people that were not involved in the survey to see how they responded. They graded the scenarios with a 4-point scale. And staff could actually comment with free text, which I didn't allow you to do because it would be too hard. And confidentiality reasons didn't want to cross that barrier. but they let their participants comment on all the scenarios. And then they were also additionally asked if they thought a colleague of the same training would make the same choice as them in the scenario. So I won't go through all the scenarios because we already read them in the email, but they'll pop up throughout the presentation. And the 11th one that I didn't send out was a 3-day history of flu-like symptoms and a fever of 37.9, and you have a slate beginning at 8:30.
Sorry, Taylor, I got a text from someone at the Alex saying they can't see or hear you.
Oh, no, okay.
Sign in or whatever you're supposed to do.
I'm not sure.
Yeah, if there's another site that can hear them, the problem's at the Alex.
Is that their site?
Yeah.
Okay, so
The Miz can hear you, I think.
Because I think the Misericordia can hear us. Yeah, okay.
I'll send her a text back.
Okay. Thank you, Dr. Fachanda.
No problem.
So for the results, they had 59 respondents, and I actually had 71 respond to my survey I sent out, so thank you for that. They had a mix of consultants and trainees, and what they found was that there was considerable variation in what people were willing to do. So there was definitely a majority consensus in some of the scenarios, but in others there was little consensus. And I'm just going to highlight some of the scenarios now. So scenario 2 and 4. So 2 was the faulty air supply. You have a leaking valve, but you have a backup tank. So do you cancel or proceed? And so some of the comments were, proceeding, you have a leaking valve, but you have enough gas flow, and you have a backup cylinder, so that's okay. It shouldn't pose a fire hazard, and they would proceed. The no decision was that if there was a leaking valve, there might be a failure in some other system, and then they didn't want to take that case in the elective case. This was the 16 degrees Celsius theater, but you can still warm your patient. The go decision was that it's a problem for the staff and not for the patient, and the no decision was that it's a problem for the staff and for the patient, so they were concerned about hypothermia in that case. And I did include how much training these people had, actually. This was you have no scavenging system, and you don't have an ICU bed ready. So for the scavenging system, they argued that you can use a TIVA instead, and that it's not important for the patient. And then the no decision was that this person doesn't routinely use TCI, and they'd be worried about awareness with their volatile anesthetic, and that it's unsafe to expose the OR staff to your volatile. The lack of the ICU bed, so this was interesting. I think this might be more of a cultural thing, but it was complete opposite reasoning. So they said it's no problem for them to stay in recovery overnight, and then the no decision was it's unacceptable for them to stay in recovery overnight. So. And then the last one I thought was interesting was the preoperative assessment. So cardiology recommended anesthesia see the patient beforehand, and that never happened. So the go decision was that this patient needs their surgery. Delaying it would put the patient at risk, and they'd give a cardiac-style anesthetic, whatever that means, because I haven't done cardiac yet, so I don't know. And the no decision was that this patient deserves a full workup prior to having an anesthetic, and they need to be stratified further before they can have their surgery. So interesting things popped up. It makes sense that consultants were more willing to proceed than trainees in general. No single person would proceed in all instances, and no single person would cancel all procedures. And most anesthetists expected a colleague to make the same choice as them that had the same training as them. And that was interesting because, as I just highlighted, that there wasn't as much consensus as people thought there would be. So people think that people are making the same choices, but that's not necessarily true. There's lots of limitations to this study, and I'll just highlight some of them because they're important. Very small sample size, so interpreting the data is actually tricky. Dr. Rosalzo pointed out to me, I think this is really critical, that how you interpret the question really influences what your answer is. So if some people say, okay, you can use a TIVA, or you can just change your anesthetic, you can bypass the problems, then you would probably put that you'd proceed for most instances. Whereas if someone read the question as being, you can't change anything, then they would probably cancel some. Workplace differences, in the UK, there's obviously workplace cultural differences between our department. Fee structure is different. And the paper highlighted in their discussion that this is not necessarily what people do when they're actually presented with the case in real life. So answering a survey question versus actually making the choice in clinical scenario is very different. So in the discussion and the free text that came out, there was different topics that arose commonly. So people citing procedure severity, urgency, obviously, concern for patient well-being, previous experience of similar situations, and then external or internal pressures for efficiency. So then I wanted to dive into what factors really contribute to someone undergoing risk-taking behavior. So the first topic is decision-making under pressure. So there's a fine balance between production efficiency and safety, and pressure to perform can lead to risky decision-making. And there's concrete examples of this in other industries that are similar to anesthesia, and like the aviation industry, nuclear power production, with cases like Chernobyl. It was cited that there was production pressures there, chemical production. So I'll just highlight an important one. So the Tenerife airport disaster, for those of you that don't know, was in 1977, and it was the worst aviation accident that occurred in history. Two Boeing 747s collided on the runway as one was taking off, and it killed 583 people. And there was lots of investigation that went into this disaster, as one would imagine. There was cited extremely poor visibility and weather conditions that day, an unusually congested runway from a nearby terrorist attack that had grounded other planes. And the KLM crew was very eager to take off because they wanted to meet their complex duty time regulations. And the Pan Am crew was also waiting to take off because they didn't want the weather to worsen. So as you can see here, this is some flavor text, but it's the recordings from the two planes. And I'll just highlight the Pan Am officer saying that he can tell the other plane is rushing, and he's held them up for half an hour, so they were already frustrated. And the KLM crew, there's some confusion as to whether they're clear for takeoff or not. And that's exactly what happened. Was they thought they were clear for takeoff, they wanted to take off, and they decided to proceed, and the Pan Am crew was still on the tarmac, and they collided with them. So this was investigated in a paper in '93, and they coined this term hurry up syndrome, and they examined other aviation accidents as well, and they identified these perceptual, cognitive, and motor errors that influenced someone's need to rush. And the majority of errors they found were made during the pre-flight and the taxi phases, and not actually during the takeoff or in the air. And they hypothesized that this was because it's when nonlinear thinking and tasks are involved for pilots. They have to decide if they need to refuel, check the weather. It's not the same thing as akin to our anesthetic when we intubate, turn on our gas, everything's routine. They have to make different decisions at that time, and that's prone to error. In their data set, they cited as the most common occurrences high workload and time compression delays, someone having a mental or emotional predisposition to rush, and then social pressures from the gate agents or the ground crew. So takeaway point, I just wanted to mention that time constraints and a predisposition to hurry can lead to critical incidents, and especially when decision-making follows a non-familiar pattern. So in relation to anesthesia, there was actually a paper that came out in '94 that looked at production pressures that anesthesiologists face, and it was in California. Again, it was a survey-style questionnaire. It was a much better response rate than the previous paper, and they actually took into account years in practice in the structure of pay and if it influenced decisions. So this is what the results looked like. They included a scale from strongly agree to strongly disagree. And just to highlight some of the survey results, they noted that an excessive workload contributed to errors in clinical judgment. People reported that hospital administration and financial motivation contributed to rushing. And there in subgroup analysis, they did find that the fee-for-service versus salary influenced people into trying to be more efficient and productive as it directly influenced their pay. and internal pressures such as minimizing time between cases, so anesthesiologists taking the responsibility to do so. And they did cite that finishing early to leave the hospital was an incentive to go quick in the OR. So I wanted to highlight this one. Anesthesiologists agreed that they had done cases where they thought the risks did exceed the benefits, but they proceeded anyways. And then in Table 5, where they asked if respondents had observed unsafe activities in the OR, I thought these ones were very interesting. So staff had seen other staff pressured to do an anesthetic in an unsafe way, and given the urgency of the case. And patients had received anesthetics despite major contraindications to surgery or anesthesia. And some staff had seen other staff do cases that were initially canceled by someone cited for safety reasons, which I know happens in probably all departments in all anesthesia locations. They also asked of respondents what they thought the strongest sources of pressure were for in their practice, and they noted that internal pressures, so wanting to get along with the surgeon, avoiding delaying surgeries, avoiding litigation, this is the US, so maybe it's different, and working when fatigued were the strongest internal pressures, and the strongest external pressure was that from a surgeon pushing to have their cases finished. So just some key points for this topic. Based on the literature, we do know we have a moderate to strong production pressure in our practice. Avoiding case cancellations, eliminating delays, and providing quick turnaround are commonly cited themes. And fee-for-service does seem to add a layer of complexity to maximize throughput. And then pressure from surgeons, this might be because they evaluate risk-benefit differently than we do, and they might not be aware of what all our anesthetic risks are. And they might have a surgical personality, which has been shown in literature before too. Okay, so workplace culture of risk. So I like this quote to start off this topic. System flaws set good people up to fail. People often find ways of getting around processes which seem to be unnecessary or which impede the workflow, and this is no normalization of deviance. So another historical example, the Space Shuttle Challenger and Columbia disasters were thoroughly looked into in the ensuing investigation, and they cited often that NASA's organizational culture and their decision-making processes violated a lot of their own safety regulations. So for those of you that don't know, in '86, the Challenger took off and exploded 73 seconds after liftoff, and it killed all 7 crew members. And it was due to this failed O-ring, which I'll explain in 1 second. This was a quote from the actual report. Failures in communication resulted in a decision to launch based on incomplete and sometimes misleading information and NASA management structure that permitted internal flight safety problems to bypass key shuttle managers. And NASA was warned many times on multiple occasions by the engineers that had designed the shuttle and had noted this faulty piece, but for whatever reason, it became an acceptable risk to deal with. So this O-ring was initially designed to not erode at all, and on previous shuttles, they had noted that it did erode up to 30%. And what initially was known as a fatal design flaw eventually became acceptable risk. So over time, they grew just to stop caring about it, and eventually it led to the destruction of the Challenger. So unfortunately, again, in 2003, Space Shuttle Columbia took off, or re-entered the atmosphere from its journey and disintegrated on re-entry. Again, the same issues were cited by the Columbia Accident Investigation Board. It wasn't the same piece, but it was the same problem. So these thermal protection tiles were never supposed to be damaged, and over time in previous shuttles they noted that these pieces took on more and more damage, and this grew to be an accepted risk when in fact it wasn't something that should have been an acceptable risk. I like lots of quotes, so this one I thought was good. Once a professional group normalizes a deviant organizational practice, it's no longer viewed as an aberrant act that elicits an exceptional response. Instead, it becomes a routine activity that's commonly anticipated and frequently used. And this normalization of deviance is hard to change, and its biggest barrier is physician engagement, and that's been looked at in the literature as well. So in terms of relating this to anesthesia, there are two papers I looked at that looked at anesthesiologists' intentions to violate safety guidelines, and they look at these violations, and they specifically examined like checking your machine, visiting your ASA 3 or 4 patients the night before, silencing your alarms intraoperatively, and they used a survey style with various scenarios for their participants, and they wanted to look at what was influencing anesthesiologists the most strongly to commit these violations. And they use this thing that I will not explain because I don't understand it, but it's the theory of planned behavior. And the strongest influence was these normative beliefs. So what that means is it's the opinion that someone believes a group of their peers would hold about them performing that violation. And in simpler terms, it just means that if your workplace tolerates risky behavior, you're more likely to undertake risky behavior. So all in all, the main conclusion of the study and what they cited as their recommendation was you may think you have a safety-conscious practice, but if your workplace tolerates risky behavior or risky decision-making, it might creep into your practice. So you need to constantly check yourself and your habits to make sure you're undergoing a safe practice. Okay, so my last topic is fatigue and decision-making. So there's a lot of literature on this topic, and there is quite a bit of literature in anesthesiology as well. And the results are variable. I know I don't see Dr. Buss here, but he was arguing with me a little bit about the literature on this topic. But I will just highlight what I found in my literature search. So we do know that fatigue does negatively impact doctors in various ways. So there's increased frequency of motor vehicle accidents seen in residents when they're post-call. Increasing frequency of needle stick injuries, and worsening mental health and stress does occur. And there's a paper that came from McMaster actually looking at anesthesia residents specifically switching from a 24-hour to 16-hour call schedule. Now in terms of patient outcomes, that's where things kind of fall off the rails a little bit. There's no increased mortality in cardiac surgery patients, even if your surgeon's fatigued apparently. And there is increased mortality in medicine inpatients, but not necessarily surgical inpatients. And that was seen twice in 2 different papers. But I really wanted to ask the question, does fatigue cause you to make riskier choices? And I found this interesting paper, which I'm going to try and relate to anesthesia. You can decide for yourselves if you think it's kind of a jump, but is entitled Sleep Deprivation Biases, the Neural Mechanisms Underlying Economic Preferences. And when I looked at all these papers, when studying risky decision-making, they often use economic gambles as a way of measuring risk-taking. So what they did was, there's 29 healthy young adults. They scanned their brains with an MRI when they were rested and then when they were sleep-deprived. And they asked them to undergo these risk-taking gambles to see how they performed when they were sleepier versus when they were more awake. And they were given the choice of either maximizing the most they could win, increasing their overall probability of winning, or they could reduce the amount they could lose. So the worst loss could be lower than what that could be. And what they found was when you are sleep deprived, your behavior shifts. So well-rested people really focused on minimizing the effect of the worst loss, and when you're extremely fatigued, everything seems to change where you become more interested in the maximal gains you can get, and you don't care as much about the minimal loss, or the maximal loss, sorry. And they call this an optimism bias. So people behaved as if positive consequences are more likely, and if negative consequences are less likely. And then they actually scanned their brains, and they found a concurrent change in what areas of the brain were being activated. And in the ventromedial prefrontal cortex, when you're sleepy, that gets activated. And that region of the brain is involved in reward and punishment. And they noticed a decrease in the anterior insula, which is important in emotional awareness and particularly negative affect, which kind of makes sense with what the results they saw. So the point I really wanted to make with this topic was that we do know that in U.S. hospitals, not necessarily, I don't know what the Canadian results are, but there's an estimated 50,000 to 100,000 people that die every year from medical errors. And we do have data that shows that sleep-deprived doctors have attentional failures and errors. Not necessarily any papers looking specifically at risk-taking when you're sleeping in medicine, but one can maybe make the jump that we do know you make riskier decisions when you're sleepy, and this might contribute to attentional failures and medical errors. So when you're tired, you're prone to attentional errors, impulsivity, and risk-taking behavior. That's all I want to say. So the last topic is quite quick. Minimizing risk. What can we do to make smarter choices? There's quite a bit of literature in anesthesia and in medicine looking at cognitive errors, not necessarily risk-taking, but lots of their recommendations in their discussion related to how to make smarter decisions. They talk about this thing called metacognition, so recognizing limitations of your memory. So it's like thinking about your own thinking, so reflecting on your choices and appreciating a broader perspective. A good capacity for self-critique and harnessing your overconfidence when you're making choices, ability to select specific strategies for best decision-making, and just asking yourself, am I using the best decision-making strategy right now? There's some tools that were suggested in some of these papers. This one was specifically about risk management, so accepting no unnecessary risk, making risk decisions at the appropriate level, so who's the right person to be making choices, accept risk when the benefits outweigh the cost, and integrate risk management into planning at all levels, which I think are all kind of common sense, but it's good to hear again. And there's this tool that's used in aviation that can be adapted maybe to anesthesia, as one of the papers suggested. It's this PAVE acronym, or a mnemonic acronym, I'm not sure. Patient, so surgical illness, comorbidities, anesthesiologist training and skills, recent experience, are you fatigued, environment, where are you, who will help you if problems arise, and external pressures, am I being influenced by production pressures right now? Take home message, okay, so back to my objectives. So how do we define risk-taking in anesthesia? Risk management and risk-taking are separate entities. We introduce risk in our practice in various ways. What factors contribute to someone making risk decisions? So production pressures, including external and internal things. Workplace culture of risk tolerance contributes to what your practice is, and fatigue may contribute to making risk decisions at nighttime. And minimizing risk, various tools and literature suggested. Practicing metacognition, so thinking about your own thinking and striving for good practice habits, and promoting a culture of safety. Okay, on to the results from the study. So I sent the emails out to the listservs at all 4 sites, and I don't actually know how many people are in the serves, like the listserv, so I don't know what my response rate was, but I did have 71 responses, which was more than the paper. I thought was funny. So this was the, so your laparoscopic chole malfunctioning gas analyzer with no FiO2 and agent analysis. Do you proceed? So I think the consensus here was you definitely cancel. The laparoscopic inguinal hernia repair, you have a leaking hose and you've got functioning O2 and nitrous, and your nitrous, I guess, and your reserve air cylinder on the machine. Do you proceed? So this is interesting. There was about 20% of people that would proceed. And again, I think it's going to come down to how you interpret the scenarios and how you think you can fix the problems.
What are the different colors?
Oh, the different colors? It's just the different bars.
Interesting.
What, sorry?
So green means cancel, right?
green means cancel. Yeah, it makes sense. Sorry, you can't really read it. The top 2 are canceling and the bottom 2 are proceeding. These people are a little bit more unsure about proceeding, but my mouse doesn't really work. I guess it's really tiny. I'm sorry.
I can't read any of your text.
Okay. So, apologies. So the top one is definitely would not proceed. Second one is probably would not proceed. The third one is probably would proceed, and the bottom one was definitely would proceed. Does that help? Okay. So laparoscopic hemicolectomy, you can't measure their temperature, but you can still warm them, and the majority of people would proceed with the case. Lap chole, the theater is 16 degrees Celsius, but you can still warm the patient. So less, as the previous paper, there was more contention over that, but here I think the majority said they'd still proceed. This is a knee arthroscopy. We're kind of all over the place here with the scavenging system offline. Do you proceed? So this was interesting. It's quite split. And I think this, again, comes down to interpretation. Can you just run a TIVA or do a different anesthetic technique? So that might have influenced if people canceled or proceeded. This one, your patient doesn't speak English and there's no translator available and the procedure is a TURP. So again, kind of all over the map, which I thought was interesting. Most would probably proceed though. Okay, the open colectomy, no ICU bed. I think this might be just how our ICU functions. It's usually you can find a place for your patient and they won't be in recovery forever. So I think people are more willing to just go ahead with the case than cancel. The IND, you have no ultrasound, but you want to put a central line in. Most people would proceed. And I think this is just a training thing. You don't necessarily need your ultrasound. I would need the ultrasound, but and even then, who knows if I can put the central line in. Open colectomy, the cardiologists recommend they see anesthesia. Never happened. I think this makes sense here. I think if we reverse it, maybe if we wanted cardiology to see our patient, they never did, that might change the answers. And then you had a busy weekend on call, and you didn't leave the hospital until 5:45, and your slate starts at 8:30. Do you proceed or cancel? So I think this is probably the most interesting one for me, at least. I think there'll be people that say you would definitely not do your slate, and there's people that say, yeah, it's no problem at all. So there's definitely going to be varying opinions on what's safe and what's not safe, and it's going to be subjective to how people think they deal with fatigue. Okay, all my references. Thank you very much. That's me.